The Medicare Part D changes for 2026 promise to save you thousands on prescription drugs, but they also hide some expensive surprises that could still drain your wallet. That new $2,100 annual out-of-pocket cap represents the most significant shift in prescription drug affordability since Medicare Part D began, yet the fine print reveals who still gets left behind. Let me walk you through exactly what this means for your medication costs this year, because understanding these changes could be the difference between manageable healthcare expenses and financial hardship. That $2,100 cap isn't just some random number. It comes from the Inflation Reduction Act, and it applies to every single Medicare beneficiary with Part D prescription drug coverage. Whether you have a standalone Part D plan or get your drug coverage through a Medicare Advantage plan, this cap works as an automatic safety net. Once you hit that $2,100 limit in out-of-pocket costs, your plan covers 100% of your covered medications for the rest of the year. Think about what that really means. If you've been rationing pills or skipping doses because of cost, this cap could completely change how you manage your health. But before you celebrate, we need to examine the details, because this isn't the complete solution many people think it is. Here's how we got to this point. Last year, the cap sat at $2,000. This year it increased to $2,100. A $100 bump that's tied to the annual percentage increase in average Part D drug spending. This adjustment mechanism means the cap will likely keep creeping upward each year, but at least it's moving more slowly than prescription drug prices have historically risen. The cap operates within a three-stage system that you need to understand to predict your actual costs. Stage 1 is the deductible phase, where you pay the full cost of your medications until you reach the maximum deductible of $650. Some plans offer zero deductible, which sounds great until you realize those plans typically charge higher monthly premiums to compensate. Stage 2 kicks in after you've met your deductible. This is the initial coverage phase, where you'll pay 25% coinsurance for both generic and brand-name drugs. You'll stay in this phase until your out-of-pocket spending hits that $2,100 threshold. Here's where many people get surprised. That 25% can add up fast if you're taking expensive medications. Stage 3 is where the real benefits happen. Once you've spent $2,100 out of your own pocket, you pay absolutely nothing for covered Part D drugs for the rest of the calendar year. Zero copays, zero coinsurance, zero additional costs beyond your monthly premium. But here's the first major catch, and it's a big one. Your monthly Part D plan premiums don't count toward that $2,100 cap, and they don't stop once you reach it. If you're paying $50 a month in Part D premiums, that's $600 annually that comes right off the top, regardless of the cap. Some people are paying significantly more than that in premiums, especially if they need comprehensive coverage for specialty drugs. What does count toward your cap? All deductibles you pay, every copay for covered drugs, and all coinsurance amounts. Prescription medications covered by your Part D plan, including those expensive specialty drugs, all count toward pushing you to that $2,100 finish line. What doesn't count is equally important to understand. Your monthly premiums, as I mentioned, are completely separate. Any drugs not covered by your specific Part D plan don't count either. If it's not on your formulary, you're on your own. And here's something that catches many people off guard. Drugs covered under Medicare Part B, like certain injectable cancer treatments and infusions you receive at a doctor's office or hospital, fall under a completely different system and don't benefit from this Part D cap at all. Now there's some genuinely good news mixed in here, and it comes from Medicare's new power to negotiate drug prices directly. For 2026, Medicare negotiated prices on 10 specific medications that treat conditions ranging from diabetes and heart disease to cancer and autoimmune disorders. Nearly 9 million Medicare Part D enrollees use at least one of these drugs, and they're seeing dramatic savings. The numbers are impressive. These negotiated drugs are costing beneficiaries about 50% less in out-of-pocket expenses compared to 2025. When researchers examined 56 standalone prescription drug plans, they found that in 2026, 7 out of these 10 negotiated drugs cost less than $100 per month out of pocket, compared to only 2 drugs meeting that threshold in 2025. If you're taking one of these 10 medications, you're among the clear winners. Your costs have dropped significantly, and when combined with the $2,100 cap, you have strong protection against catastrophic drug expenses. But if your expensive medication isn't on that list of 10, you're still vulnerable to high costs until you hit the cap. Let me give you a real-world example of how this plays out. Say you take a brand-name drug that costs $800 per month. Under the new system, after meeting a $300 deductible, you'd pay 25% of that $800, which is $200 per month. You'd hit the $2,100 cap in about 9 months, and your last 3 months would be free. That's still $2,100 out of pocket, plus your monthly premiums all year long, but it's far better than paying $200 every month for 12 months. The problem is, not everyone fits neatly into these calculations. Some people take multiple expensive medications that push them to the cap quickly, while others might spend just enough to stay in that 25% co-insurance phase most of the year. The cap provides the most protection for people with the highest drug costs, but offers less relief for those with moderate expenses who never reach the threshold. There's also a new option that might help with cash flow management. Medicare now offers a prescription payment plan that lets you spread your out-of-pocket costs across the entire year through monthly payments, rather than paying large amounts each time you pick up medications. If you're expecting to hit that $2,100 cap, you might pay somewhere between $175 and $232 per month, instead of facing unpredictable spikes when you need expensive drugs. This payment plan doesn't reduce your total costs. You're still subject to the same $2,100 cap, but it can make budgeting more predictable. You'd still need to pay your monthly Part D premiums separately, so this isn't a complete solution to monthly expenses. Who really wins with these changes? Seniors taking multiple high-cost medications see the most dramatic improvement. If you've been spending $5,000 or $8,000 or even more annually on prescriptions, cutting that to $2,100 plus premiums represents massive savings. People with chronic conditions requiring expensive drugs, especially if those drugs happen to be among the 10 negotiated medications, are experiencing a fundamental shift in affordability. The cap applies uniformly regardless of income, which means even wealthy beneficiaries get this protection. That's different from some Medicare benefits that phase out at higher income levels. Whether you're living on Social Security alone or have substantial retirement savings, you get the same $2,100 cap. But let's talk about who still gets burned, because the fine print reveals some significant limitations that could catch you off guard. First, those monthly premiums I keep mentioning aren't just a minor detail. Part D plan premiums have been rising steadily, and some comprehensive plans charge several $100s annually. While your out-of-pocket drug costs are capped, your premiums could easily add another $500 to $2,200 to your annual prescription drug expenses, depending on your plan choice. The formulary system remains unchanged, and this is crucial to understand. Every Part D plan maintains an approved drug list called a formulary. If your medication isn't on that list, the $2,100 cap provides zero protection. You could be paying full price for a non-covered drug while simultaneously paying co-insurance toward the cap for your covered medications. This creates a situation where you might have some drugs counting toward your protection while others offer no protection at all. Prior authorization requirements, step therapy protocols, and quantity limits all remain in place. Your plan can still require you to try cheaper alternatives before covering your preferred medication, or limit how much you can get at one time. The cap doesn't override these management tools that plans use to control costs. For people who need Medicare Part B drugs, those injectable and infused medications administered in medical facilities, this entire discussion becomes irrelevant. Part B drugs fall under different cost structures and don't benefit from the Part D cap. If you're receiving expensive cancer treatments, certain arthritis medications, or other specialized therapies through Part B, you're dealing with completely separate out-of-pocket limits and cost-sharing rules. There's also a timing issue that affects real-world budgeting. The cap operates on a calendar year basis, resetting every January 1st. If you're diagnosed with a condition requiring expensive medications late in the year, you might hit the cap quickly and enjoy a few months of free drugs, but come January, you're back to square one with deductibles and co-insurance. The broader policy picture reveals additional concerns. While 10 drugs received negotiated pricing for 2026, thousands of other prescription medications remain subject to whatever prices manufacturers choose to charge. The cap limits your total exposure, but it doesn't address the underlying issue of high individual drug prices for most medications. Some policy experts worry that drug manufacturers might respond to the cap by raising prices on medications that aren't subject to negotiation, knowing that the worst-case scenario for consumers is hitting the $2,100 limit. This could create upward pressure on drug prices in the initial coverage phase, where you're still paying that 25% coinsurance. There's also the question of plan design changes. Insurance companies might adjust their formularies, premium structures, or coverage policies in response to the cap. Some might raise premiums to offset the increased costs they'll bear once beneficiaries hit the cap. Others might tighten their formularies to exclude more expensive drugs, forcing patients toward cheaper alternatives, or pushing them to pay full price for non-covered options. The reality is that this cap represents a significant step forward, but it's not the comprehensive solution to prescription drug affordability that some people expected. If you've been spending thousands annually on medications, you're likely seeing substantial relief. But if you're dealing with moderate drug costs, or if your medications fall outside the system's coverage, your experience might be more mixed. Looking ahead, Medicare will continue expanding the drug negotiation program. More medications will receive negotiated pricing in future years, which should help more beneficiaries see direct cost reductions beyond just the catastrophic cap protection. But the pace of that expansion means many people will continue facing high costs for specific drugs in the near term. The prescription payment plan option deserves another look, especially if you're someone who typically hits the cap each year. Instead of facing large out-of-pocket expenses when you fill expensive prescriptions, you can smooth those costs into predictable monthly payments. This doesn't save money, but it can make the financial impact more manageable month to month. For planning purposes, you need to calculate your likely annual costs, including both the potential $2,100 in out-of-pocket expenses and your monthly premiums. If you're taking expensive medications, research whether any of them are among the 10 drugs with negotiated pricing, because that could significantly reduce your costs before you even approach the cap. Review your Part D plan's formulary carefully each year during open enrollment. The cap provides protection against catastrophic costs, but only for covered drugs. If your medications aren't on your plan's formulary, you might need to switch plans or face full price costs that don't count toward any protection. Consider the trade-offs between plans with different premium and deductible structures. A plan with zero deductible might sound appealing, but if it charges significantly higher monthly premiums, you might pay more overall than choosing a plan with the maximum $615 deductible, but lower premiums. The bottom line is that the $2,100 cap represents the most significant improvement in Medicare prescription drug coverage in decades, but it's not a magic solution to all medication affordability issues. It provides crucial protection against the worst-case scenarios that have forced some seniors to choose between medications and other necessities. For people with the highest drug costs, it's genuinely life-changing. But the system still leaves gaps. Monthly premiums continue rising. Non-covered drugs offer no protection. Part B medications fall outside the system entirely. And the underlying issue of high prescription drug prices remains largely unaddressed for most medications. As we move through 2026, the real test will be how these changes affect actual beneficiaries dealing with real medical conditions and real financial constraints. The cap provides a ceiling on costs, but for many people, that ceiling is still uncomfortably high when combined with premiums and other healthcare expenses. The Medicare prescription drug landscape has changed dramatically, but it's still complex, still requires careful planning, and still involves significant costs for many beneficiaries. Understanding exactly how these changes affect your specific situation, your medications, your plan, your budget, remains as important as ever. The $2,100 cap is a powerful new protection, but it's just one piece of a larger puzzle that every Medicare beneficiary needs to solve for themselves.